Hi everyone, in this video I'll be discussing drugs acting on bladder and bowel. So these drugs are very important because they are frequently asked in your exams. Not only that, patients come with symptoms also. So let us start and understand with a simple MCQ. At the end of the video, we'll come back and solve the MCQ and we'll understand in a case-based manner. So let us start our journey. And this is the patient. 30-year-old male had UTI and complaints of frequent and sudden urge to urinate, and that is difficult to control. So he had a urinary tract infection. He had frequent and sudden urge to urinate, and it is difficult to control. His treating physician gave him antibiotics and wanted to control this symptom and started on following therapy for his symptoms. Which drug was started? Methanacol, fluvoxamine, finasteride, flutamide. So we'll come to the answer later. First of all, let us understand patient is having UTI and along with that he has a sudden urge to urinate. Now, to understand that, we need to understand a terminology. What is that? The terminology is called as urinary incontinence. Urinary incontinence. Now, what do you mean by urinary incontinence? Now, usually the urine can be controlled. Okay, so if you have urge to urinate, you can control for some time. But in these people who have incontinence, they cannot voluntarily control that. That is the meaning of urinary incontinence. Now, in urinary incontinence, we have three types. One is called the urge incontinence. Second problem is the stress urinary incontinence. And one more is called the overflow urinary incontinence. Now, what is the problem in urge incontinence? Urge incontinence, the problem is this is the bladder. This is the bladder and this is the urethra. Now, in urge incontinence, the problem is detrusor is irritated. So, detrusor is irritated. Even a small amount of urine is collected, the patient has to go to the bathroom. He has to pass the urine. So, there is a sudden urge to pass urine. Sudden urge to pass the urine because the detrusor is hyperactive. So suddenly the detrusor will contract, he has to go to the urine. Usually we know that bladder should fill, then only we get the urge. But even with small amount, the urge is increasing. So that is why it is called urge incontinence and the condition is called overactive bladder. So in certain infections like UTI, which we are discussing now, the patient is having overactive bladder. Even with small amount of urine, he has a sudden urge to pass urine. Now, how do we manage this? Let us understand this first. Overactive bladder. Now, to understand the treatment of overactive bladder, let us understand what are the receptors on the bladder. So, this is the bladder. This is the prostate, right? And this is the trigone of the bladder. And this is the muscle called detrusor. This is called the detrusor. And the alpha receptors are present here. So in the prostate, it is present as well as it is also present in the trigone of the bladder. Now, detrusor is supplied by the beta 2, beta 3, which are sympathetic. Detrusor is also supplied by a receptor called M3. So remember, when the detrusor is activated by beta 3, it will relax, but M3 will contract. M3 will contract the detrusor. Now this one, if it constricts, if alpha 1 constrict, the urine will not come because it's like holding the trigone and also holding the prostatic part of urethra. So when you are stimulating sympathetic system, beta 2, beta 3 and alpha 1, they will cause urine retention. They will cause urine retention. Why? Point to understand is beta 2, beta 3 relax the detrusor and alpha 1 constrict the sphincter, the prostatic part. So the urine is retained. But M3 is the one which will cause evacuation of urine. Evacuation of urine is done by the cholinergic system. Now in this patient, already the M3, that is detrusor, is hyperactive, it is contracting repeatedly. Now, if you want to manage this patient, what should we do? Either I should stimulate the beta 2 or beta 3. So I should give the agonist for this, or I should give the antagonist for this. So if I use the agonist, what you see is urine retention. If I give the antagonist, the M3 is blocked, then you will again see urine retention. So either I should use the anticholinergic drugs. So you know what you mean by anticholinergic drugs? These are the drugs which blocks the muscarinic receptor. Or I should use the beta agonist. Now, can I use alpha 1 agonist? Because if you use alpha 1 agonist, it will block the complete urine from coming out. So what we can do is we can use beta 2 or beta 3 agonist. That is the best idea. So either we should use anticholinergic drugs which block M3 receptor, so the urine is retained. So anticholinergic drugs cause urine retention, or we should give the sympathetic drug which stimulate the beta 2 or beta 3. So what are the drugs used for overactive bladder? Let us understand. Drugs for OAB means overactive bladder. The mnemonic to understand is my friend dost. My friend dost. So M stands for a drug by the name mirabegron. So mirabegron, if you know, it sounds like mera bladder. So it is used for bladder condition. So another drug which also ends with begron is vbegron. So the mechanism of these drugs are, these are beta 3 agonists. So we have discussed that beta 3 agonists are used in overactive bladder because they retain the urine. Now F for fesoterodine, and another drug called flavoxate. The another drug name is flavoxate, and D for darifenacin, and O for oxybutinin, and S for solifenacin. Then we have another drug called trospium. Now trospium is not going to cross blood-brain barrier. The reason why we should know this is because most of this can cross blood-brain barrier and cause anticholinergic side effect in the brain, but this will not cause any CNS side effect. One more drug what we have is tolterodine. Now remember, fesoterodine after metabolism will give rise to tolterodine, and fesoterodine is called as prodrug. It is the prodrug. So these are the drugs used for overactive bladder, my friend dost. Now remember, these friend and dost, these all drugs are anticholinergic drugs. All these are anticholinergic drugs, and mine is the beta 3 agonist. Now in this mnemonic, you can add one more O for a toxin called Ona botulinum toxin A. So Ona botulinum toxin A is given locally into the bladder, and it should not be given systemically. So it is also used to treat overactive bladder, but the mechanism of action is it decreases presynaptic acetylcholine release. So what happens if you don't release acetylcholine? Acetylcholine cannot act on M3 and the urine will not come out. So that's the reason why the Ona botulinum toxin is used locally in this case. So the mnemonic is my friend dost. Remember, these two are beta 3 agonist, and this is a drug which decreases presynaptic acetylcholine release, and friend dost, these drugs are anticholinergic drugs. So that is for overactive bladder. Okay, sir. The next problem is something called stress urinary incontinence. Now the problem here is, this is the bladder, this is the urethra. So this is the pelvic floor. This is the pelvic floor. Now here what happens? Some urine is filled up, not to the extent of urgency, whenever the patient coughs, so whenever there is increase in intra-abdominal pressure, whenever there is increase in intra-abdominal pressure like coughing, sneezing, skipping, whatever, so that this urine will not be held. So the sphincter cannot hold the urine will come out. So that is called stress urinary incontinence. So urine will come out through the urethra. Sometimes even the pelvic floor, the muscles are weak. That is also going to cause stress urinary incontinence. So the major treatment for this is surgery and pelvic floor exercise. But drugs are not so much useful, but one drug that is specifically asked in the exam which can be used is duloxetine. Now duloxetine belongs to an antidepressant class called SNRI. SNRI stands for serotonin norepinephrine reuptake inhibitor. Why this is used? Because it has additional property. What is additional property? Additional muscarinic blocking property. So it will block the muscarinic receptor. You know, if you block muscarinic receptor, it is called as anticholinergic or antimuscarinic. And just now we told, if you block muscarinic, the urine will get retained. So this will cause urine retention. So what is the problem in stress urinary incontinence? As they increase the intra-abdominal pressure, the urine is coming out. So we are giving the drug so that the urine is retained. So that's the reason why duloxetine is used. It causes urinary retention. Why? It has muscarinic blocking property. So that is the story of stress urinary incontinence. Let us understand what do you mean by overflow incontinence. What do you mean by the overflow incontinence? Here the problem is, let me take, this is the bladder and this is the prostate. Now what happens, as the male patient who are elderly, the prostate will enlarge and that is called BPH. Now when the prostate enlarges, the outlet where the urine has to go will close. When the prostate enlarges, it will close the outlet. So what happens, the urine keeps on accumulating. So there will be overflow and patient cannot pass the urine completely. And even if he has passed, he will feel that there is some urine remaining. So there is overflow incontinence. Second problem is the bladder itself is not contracting. So the problem is the bladder is atonic. So there is a condition called atonic bladder. When the bladder doesn't contract, the urine accumulates and that is called overflow incontinence. So we need to understand the management of BPH and the management of atonic bladder. So these are the conditions where you see overflow incontinence. Here the problem is urine is not going out. So remember, can we use anticholinergic drugs or drugs for causing urine retention in this case? Can we use anticholinergics here? Can we use anticholinergic drugs or any drug which causes urine retention here? No, they are contraindicated. So already the problem is urine is retained. Don't give anticholinergic drugs. That's why in benign prostatic hyperplasia, you should not use atropine group of drugs because they are anticholinergics, or any drug which retains urine should not be used in BPH or atonic bladder. Clear? So let me tell you about the management of BPH. First I will tell you about BPH, then we will come to the management of atonic bladder. Benign prostate hyperplasia or benign hypertrophy of prostate, whatever. So the problem here is, this is the bladder, this is the urethra, and this is the prostate. So normally the prostate is in normal size, but when the person ages, the androgen effect will make the prostate to enlarge. So here we have the receptors called alpha 1A, and they will be hyperactive because whenever the prostate will be enlarged, this passage keeps on becoming narrow. So when it becomes narrow, patient will not be able to pass the urine completely. So it is called overflow incontinence. So there is a component here. The component is a dynamic component. So dynamic component means in this place what happens, the adrenal systems, whenever the prostate enlarges, it will try to close and it will open in. Try to close open. So there will be increase in the tone of the prostatic smooth muscles. So here there is increase in prostate smooth muscle tone, and that tone is maintained by the alpha 1A receptors. So that is called dynamic component. Now the prostate is enlarged prostate. So prostate is enlarged. Now when the prostate is enlarged, it is the static component. Static component. The meaning is when the prostate is enlarged, you cannot make it shrink. It's already enlarged. You cannot do anything. Dynamic means sometimes it will obstruct, sometimes it will open. But this is because of the hyperactivation of alpha 1A receptors. So what we can do in BPH? The alpha 1A is the one which is hyperactive. Block it. So block it. If you block that, this action will be not there and the urine will flow easily. So the drugs which are used for this dynamic component are alpha 1 blockers. The drugs used are called alpha 1 blockers. For example, the drug called prazosin, terazosin, so they end with zosin, doxazosin, and a drug called alfuzosin, bunazosin, like that, bunazosin also. Now here, prazosin, terazosin, doxazosin, alfuzosin, they are used in BPH, but they are preferred if the patient has hypertension and BPH because they don't act on only alpha 1A, they also act on alpha 1B. So alpha 1A is present in the prostate part of the urethra and alpha 1B is present in blood vessel. So we want action in prostate, not in blood vessel. But if the patient is having both BPH and hypertension, then I can prefer these drugs. But in these drugs, remember alfuzosin is approved for only BPH only, not for hypertension. Other drugs you can manage BPH and hypertension conditions. So prazosin, terazosin, doxazosin, alfuzosin, bunazosin, they all end with zosins. So the problem here is when we start the drug, there is a chance of hypotension. We call it as first dose hypertension. You can avoid that by giving the dose at the night time and giving at lower dose. Fine. But even with that measure, some people suffer with hypertension when we use these drugs. So then we came with one more idea. Why should we trouble the blood vessel? Let us block only alpha 1A receptor. So we have alpha 1A selective blocker. And the name of that is called tamsulosin. So they end with osins. Tamsulosin. They end with osin. One more is silodosin. Again, you can see it ends with osin. And these are approved for BPH only. These are approved for benign prostate hyperplasia only. They don't have action on blood vessels, so they don't cause hypertension. Now, when you are using tamsulosin, be careful. One of the adverse effects with that is intraoperative floppy iris syndrome. So intraoperative floppy iris syndrome is a complication with that. Now, why should I know this problem? The problem is most of the elderly male patient have cataracts, and if you are putting the patient on cataract and he is already on tamsulosin, there is an intraoperative complication. The iris will become floppy and it's very difficult to put the lens there. So that's the reason tamsulosin has to be stopped at least 15 to 20 days before surgery, and then cataract surgery has to be done. And that's why this question keeps on coming again and again. So these drugs which are acting on alpha and blocking it, these are fastest acting. So these group of drugs are fastest acting drugs in the management of the BPH. Another important thing is, most important thing in if the prostate is enlarging, surgery is the best thing. But patient may not go for surgery, so that time we can reduce the prostate size. And remember, we have a drug called finasteride and a drug called dutasteride. So what do? These finasteride and dutasteride, we have the hormone called testosterone that becomes dihydrotestosterone, and this is responsible for enlargement of prostate. And the enzyme which converts this is by the name 5-alpha reductase. So the enzyme is called 5-alpha reductase, and if I don't allow testosterone to become dihydrotestosterone, the prostate enlargement will stop. So These drugs, finasteride, dutasteride, they are 5-alpha reductase inhibitors. Finasteride, dutasteride are 5-alpha reductase inhibitors. And what is the advantage of them? They decrease the prostate size. So the problem in statin component is prostate is enlarged. So when you use them, the prostate size decreases. Now, will that happen in 1 day, 2 day? No, it will take at least 3 to 6 months. So these are slower acting drugs. And this was the MCQ asked. Which of the following drugs decrease the prostate size? Finasteride and dutasteride. Now, one more advantage, these drugs, terazosin and doxazosin, they have a moiety called quinazoline moiety. These have shown to produce prostate smooth muscle apoptosis. So this is the update from Goodman and Gilman. These drugs, terazosin, doxazosin, they have a moiety called quinazoline moiety, which are shown to produce prostate smooth muscle apoptosis. So here the problem is again smooth muscles. So if they undergo apoptosis, again it's good for the patient only. So that is how we manage the BPH, the fast acting component, the alpha blocker, the slower acting, that is 5-alpha reductase inhibitors. Usually the urologist will start with the faster acting one. If the patient is not responding to that, then they will add up the 5-alpha reductase inhibitors. And if the patient still is not responding, then the main thing is surgery. Surgical management has to be done with this. This is the management of the benign prostate hyperplasia or benign hyperplasia of prostate. So this is an example of overflow incontinence. The next important example for overflow incontinence is atonic bladder. So atonic bladder is due to the nerves not working properly, so the bladder is not able to contract. In atonic bladder or neurogenic bladder, the drug what we have to do is we have to stimulate M3 receptor. So we have to give M3 agonist drugs. So if you use M3, they will contract the detrusor and the urine will come out. So what are the drugs we use for atonic bladder? The drugs are called as bethanacol, and we have anticholinesterase drug like neostigmine, and one more drug is called pyridostigmine. So these are the other options what we have for atonic bladder: bethanacol, neostigmine, pyridostigmine. They are used for atonic bladder. So these are the bladder conditions. Now, one more problem what happens is the post-operative conditions. Post-operative. Now, post-operative, there are two important problems. One is post-operative urine retention. And one more problem is post-operative paralytic ileus. Post-operative urine retention and post-operative paralytic ileus. Now, when we take a patient for surgery, we put a patient on anesthesia. When you give anesthesia, the surgery is done, patient will be in recovery stage. Now, due to anesthesia, the motility of GIT, the motility of the bladder would have reduced. So, usually after some time, the flatus is passed, the urine is passed. If it is not passed, then we call it as post-operative urine retention and post-operative paralytic ileus. So, how do you know patient has passed the flatus? You have to ask the history. If the patient is not telling, take the stethoscope, put it on the abdomen, you will see the bowel sound. Or we'll tell the patient to urinate. We open the tap and we tell the patient to urinate, try to urinate. If it is not happening like that, then we have to use the drugs. So for these conditions, we have to use the drugs. They are same drugs what you discussed: bethanacol, pyridostigmine, neostigmine. So the bowel condition what we are going to discuss is what we told you as post-operative paralytic ileus, commonly asked question in your exam. So urine retention post-operatively or paralytic ileus, bethanacol, pyridostigmine, neostigmine can be used. Recently the question was asked, let me take it as a case. Patient had a history of bronchial asthma and now he has post-operative urinary retention. So there are two options. What will you choose to this patient? Bethanacol, or will you choose tamsulosin? So this is one of the NEET PG question. Try to answer this. Pause the video. Patient had post-operative retention. What do you use? Bethanacol or tamsulosin? If you have chosen bethanacol, remember bethanacol is a cholinergic drugs, and cholinergic drugs can cause bronchoconstriction. So already patient has asthma, so it can worsen that. Sir, tamsulosin is used for BPH, right? Yes, it is used for BPH. Now here the problem is urine retention. I told you this is the bladder, and we have the alpha 1 receptor here. So what is the role of alpha 1? To retain urine. If I block this, the urine will come out. So there is urine retention. If I block this, then urine will come out. So tamsulosin is used in post-operative urine retention. It is not officially approved. It is off-label use for this. And this question came in the recent NEET PG exam. That's why I'm asking you. In asthmatic patient, don't give bethanacol, not bethanacol, even pyridostigmine, neostigmine, because they increase the cholinergic activity. So you can use tamsulosin. So urine retention, paralytic ileus, I told you bethanacol, pyridostigmine, neostigmine can be used. So that is about drugs acting on bowel and bladder. So I told you with a case history, with an MCQ we started, and I told you what is urinary incontinence, what is urge, what is stress, what is overflow. For the urge, it is also called as overactive bladder. The mnemonic is my friend dose. And stress urinary incontinence, it is mainly surgery, pelvic floor exercise, and a drug called duloxetine. But any drug which causes urine retention should not be used in overflow incontinence, because there is already retention of urine. So what you have to do is you have to use the drugs for atonic bladder, that is bethanacol, neostigmine, as well as pyridostigmine. For BPH, I told you there are two important ones: alpha blockers, zosin drugs, or alpha 1A blockers, osin drugs. The slower acting drugs are 5-alpha reductase inhibitors, finasteride, dutasteride. They decrease the prostate size, but they take time. Post-operative urine retention, paralytic ileus, you can use bethanacol, pyridostigmine, neostigmine. But if it is a patient with asthma and post-operative urine retention, you can use tamsulosin, because it's an alpha blocker. It's an off-label indications for that. That is asked in your exam. Okay, so coming back to the question, we started our journey from here. A 30-year-old male had UTI and complains of frequent and sudden urge to urinate that is difficult to control. So the infection triggering the frequency and sudden urge to urinate, it's a case of urge incontinence. So it is a case of overactive bladder, OAB. And he was given antibiotics so to treat UTI, and he has to be controlled with the symptoms. What is the symptom? Sudden urge to urinate. Suppose he has to attend the class, he has to sit for the exam, so he has to go to toilet repeatedly, then he cannot sit. The overactive bladder. So in that case, you have to treat the symptoms. So, and wanted to control his symptom and started on following therapy for his symptoms. Which drug was started? Bethanacol. Bethanacol, is it the answer? Now bethanacol is M3 agonist. It increases evacuation of urine. So already urine is coming out. So we cannot use it. It is not used. So bethanacol is used in post-operative ileus as well as urine retention as well as atonic bladder. Flavoxate, yes, it's an anticholinergic drug, M3 antagonist, that is used to treat overactive bladder. So the answer will be this. Finasteride is a 5-alpha reductase inhibitor. 5-alpha reductase inhibitor that is used to treat benign prostate hyperplasia or BHP or BPH. So the problem there is overflow incontinence. So here they have not mentioned that. Flutamide is an androgen receptor blocker. Androgen receptor blocker, and that is used to treat prostate cancer. Prostate cancer. So the answer for this question is flavoxate. Okay, my friend, those drugs are used. So this is how we can approach the videos also. It's not like you tell the theory. You can start with the MCQ also and end with that. So with that, we have finished drugs acting on bowel and bladder. Thank you all.